One of our patients came in feeling great and left with a pancreatic cancer diagnosis that saved his life. Another was afraid to eat without his GLP-1 shot.
In today's episode of the Out of Network podcast, we dive into the rapidly growing world of wellness. The scans, the labs, the medications, and the hype. What's helping? What's harming? And how do we keep patients truly at the center of it all? We promise you're going to enjoy this episode. So, good morning.
Good morning.
How are you, Dr. Seth?
I'm doing well, Dr. Parker.
Good.
Good to see you.
Good to see you. I think I would like to start today's conversation, obviously being two outstanding concierge physicians. I'd like to really start the conversation about the wellness services that you offer in your practice. Obviously, as concierge physicians, we have the ability and the time to really talk about more wellness with our patients and really getting into that functional medicine piece. Let's talk a little bit about labs. I know there's a lot of push nowadays for patients who are hungry and interested in looking at some advanced markers to identify health trends, what their metabolism is doing, what their hormone levels are doing. Talk to me a little bit about that. Do you offer those tests? Are they important? Do patients think that they are of value?
Yeah. So I think the way I would respond about any sort of these functional health biomarkers, which are very, very popular, very, very hot. It seems like every time I open up Facebook, something's popping up on my feed about it. You know, the labs are there, but I think it also speaks to the wellness trends in the country and the world right now. There's the evidence-based medicine, which is what traditional medicine is, hospital medicine, clinical medicine, evidence-based. These are, FDA-approved medications, etc. Then, the flip side is like, stuff that is not healthy for you, stuff that is bad for you. And then in the middle, there's a very, very large gray area of wellness. Mm-hmm. And I think these biomarkers are on the verge between the evidence-based and the wellness world. So yeah, previously in clinical practice, these labs are ordered many, many times a day by many, many doctors in every hospital in the country, right? So for example, like a comprehensive metabolic panel, I order those 20 times a day in the hospital, right? Mm-hmm. That being said, when they're sold in the public as checking your liver and checking your kidney, it's a good screening tool. And that is something that is done in practice and is actually paid for by insurances once or potentially twice a year. Mm-hmm. But when it's advertised as, functional biomarkers, there's a lot of marketing behind there, right? Right. So then on top of it, there's certain brands that sell like very, very large packages of these labs where, there's labs like apolipoprotein B, high sensitive C-reactive protein. These are great tests when used in the right clinical setting. But if they're for screening, it sometimes makes it a lot more difficult for the patient to see what is wrong. Mm-hmm. All it says is something's abnormal. It doesn't say what is abnormal. And in most cases, it increases anxiety in these patients.
So do you think we are able to get enough information from what I'll say these basic labs that you order in the hospital or we order in the clinic? Do you think that is enough information for you as a physician to take and make good clinical decisions with?
I think in a screening process, because I think it differs if the patient's sick and coming to me and I'm ordering a large amount of lab tests versus somebody's like, I'm doing fantastic. I run 10 miles a day. I eat very healthy. I've ordered these labs. And if they're normal, I don't think I need additional testing unless there are certain cancer screening markers or cancer screening tests. But if they're sick, they're not feeling good, they've lost weight, all sorts of stuff. and then, I order a set of tests and they are not giving me the definitive answer, then the next step is to investigate further, right? But I mean, and that's that. I think that's where the crux of of being a physician is so difficult,
right?
Is the screening versus the sick. Who is sick? Who is healthy and just wants to know more about their health,
and not putting yourself or the patient in a situation that fosters more unnecessary testing. For example, are these tests enough to change management? So, obviously, I see patients all the time who are very interested in their health, who want to take it to the next level, and they will bring me a lab slip that says, "Oh, I read on the internet that it's important to look at highly sensitive CRP. It's important to look at ApoB, ApoA1, LPPLA2, look at cystatin C with kidney health." And I'm happy to order it. I know how to interpret it, but I sometimes fall on the grenade and say, is this really going to change management? You are already healthy. How is this going to change management? And you bring up the point, is that costing the consumer a little bit more for these unnecessary tests, or is it really benefiting them in the long run?
A great example is these kidney statin screening tests. They're wonderful biomarkers if they're all normal. They may give a very complete picture as long as you're normal. If they're abnormal, they would have been abnormal beforehand too. Like, your baseline creatinine would have been probably abnormal. What does it lead to? Well, potentially liver ultrasounds, potential liver biopsies. Liver biopsies come with risk of complication, hemorrhage, all sorts of issues. I've worked in the hospital. I've seen good things and I've seen some risks associated with it. So as a physician, one of the things that I struggle with is that balance. Is that I could go down the rabbit hole for every single one of my patients, order 1 billion tests. But then of those billion tests, one of those tests could lead to harm or even worse. And am I willing to risk that? Well, no. So how do I balance that? And also, please our patient too.
It's a fine balance.
Especially as a concierge physician, you want to make sure that you're doing what's right for the patient, but at the same time, you're also understanding the service that you provide.
Right. And I think in certain situations and certain disease states, and knowing the patient clinically and whether or not this will benefit them in the long run.
Right.
So it wants me to jump forward to the idea of whole body MRI imaging and the importance of that. First, do no harm, right? Obviously, there's a lot of services and these wellness trends out there that may or may not potentially change things. But talk to me about your experience with whole body MRI imaging, and have any of your patients asked you about that? And have you ordered whole body MRI imaging?
I've had a few patients ask me for whole body MRIs. I have not ordered them, and I'm going to be honest with you. In part of that do no harm, one part that I like to hold to is if, physical harm, obviously, but like financial harm is also an issue. And I want to make sure that the risks and benefits are weighed out in those situations. So I sat with the patient in this situation, and I asked them, what is your purpose for looking for MRIs? Well, I want to reduce my risk for breast cancer, and I want to reduce my risk for this. Have you had a mammogram? Well, no, I haven't had my mammogram. Okay. Have you had your colonoscopy? No, I haven't had my colonoscopy. Well, let's start with those screening modalities first, right? Because those are time tested and true.
Right.
The colonoscopy is the best example. Of all the things in medicine that we've done for screening, there's nothing better than a screening colonoscopy, right? Reduces mortality significantly. And so I often tell my patients, let's first check those boxes. If after that, your mind is still saying, I need to evaluate, then we can come to that bridge and cross that bridge when we get there. But I understand that you've been involved in this. What do you think about that?
I think it's outstanding, and maybe it's because of a situation I had with a patient. I get the financial strain. These are very expensive tests. And obviously, it can set the patient up for other situations too. Obviously, how many times do we order CT scans and we identify pulmonary lung nodules? And now we're exposing that patient to multiple tests, every year to monitor for that and the radiation exposure. But I'll tell you, when I ordered an MRI whole body scan on a patient, this was a fairly healthy patient, a little overweight, alcoholic, and all of his blood tests were completely normal. ALT, AST, GGT, liver enzymes, alk phos, completely normal. And there was a small lesion that lit up at the head of the pancreas. And it scared me, scared the patient. And when I sent the patient to GI for a workup, the GI even said, this is nothing. The blood tests are fine. And it still didn't really set well with me. We kind of sat on it for 3 or 4 months. They said, let's consider doing an endoscopic ultrasound in 3 months and see if it changed. So we did that, and that specialist said, I'm a little concerned enough that we need to take this a step further. I ended up having a biopsy and was pancreatic adenocarcinoma. So, I look at the whole body MRI in this particular situation as something that saved his life.
So if I could run on top with that, so that pancreatic lesion, biopsy pancreatic adenocarcinoma, was it a solitary lesion?
Yes.
So then the next step would have been surgical management.
Correct.
So he would have gone through the Whipple, assuming that that's what his surgery would have been.
Ultimately wasn't a candidate for it for whatever reason.
Okay. But that's a humongous thing. One of my closest friends had a very similar situation with his father, where a screening modal ultrasound caught a large mass on the pancreas. It turned out it was a pancreatic malignancy. He underwent, a very extensive Whipple surgery. And for those people who don't know about pancreatic cancer, the worst part about these cancers are you don't find them until the symptoms start coming up, painless jaundice or whatnot. And at that point, it's generally too far gone. That's an amazing story.
Yeah. I mean, I look at us in medical school that we are really taught only 4 set of guidelines for cancer detection. 4. And even then, so it's breast, cervical, colon, and prostate. And even then, we miss I'll take a step back. We are only able to identify up to 14% of cancers, even following those guidelines. So that means 86% of the time we're missing something. And these are true statistics. So that's why I say I think the MRI, if the patient has the means to do it and they may or may not have certain risk factors, I think it's something to think about. And something in my concierge practice we talk about all the time. And I think it can definitely give us a good baseline. How do you screen for aneurysms?
Right.
We don't.
There's certain people.
There are certain, correct,
right, yeah.
Correct, at certain ages. And so, but I think there's a lot that testing can show us that can certainly help.
I was just thinking about that because if you smoked for 20 years and you're 60 years old, based on the radiation risks and benefit, the CT of the lung screening has been approved, and that insurance and Medicare will pay for it, etc. That being said, if you smoked for 10 years, right, it won't be approved. So I mean, at the end, let's say, I have friends who smoked for 5 years, 10 years, and what's their risk? Is it 0? Are we confident about that?
Yeah.
And I think like that's where the problem with public data is so difficult, because the data is so massive,
right?
And it tends to obviously draw a very, very large population, and it's hard to identify that's unique individual and the unique individual's situation.
Yeah.
But a lot of times we have patients who are like, well, my risk factors are this, my risk factors are this. I had a family member who had lung cancer. Those are very, very reasonable concerns.
Yeah. Yeah. When you think about patients, and obviously I talk to my patients all the time about certain conditions, and we spent the last 5-10 minutes talking about cancers. But is cancer the leading cause of death in the United States? No, it's not. It's heart disease. And heart disease kills more Americans than cancer in this country every year. So what are we as physicians doing a good job for really screening for cardiovascular disease? Going back to what we talked about earlier with some of these biomarkers, and yes, I will say that some of them may make me want to put them on a statin a little bit sooner.
Yeah.
Some patients are not always eager to do that, but certainly if you pay attention to family history and age and gender and other risk factors, that may account for that. But I think it's important to talk to patients about cardiovascular risk and cardiovascular screening. So talk to me in your practice about what you do for patients.
So we have our own stress EKG.
Okay.
But of course, the real initial screening for patients is history, lab tests, screening labs like lipid panels, A1Cs, to make sure that they're in optimal vascular and cardiovascular health. Can you walk a mile? Do you have chest pain when you walk up the stairs? I think those things are obviously the most important thing. People knock on those things like, well, no, I really want a blood test. Have you walked up 4 flights of stairs? No, I have not walked. Okay, well, let's talk about that, right? But then what we do is the stress EKG, and the stress EKG does a fantastic job at identifying their cardiac risk in times of cardiac stress. A lot of people say stress is, mental and physical stress. The cardiac stress is when the heart rate is really, really high. And so we have our EKG system that is able to tell our electrical activity when a heart rate comes up to 180 and for a period of time. And you get really, really great data from it. It is very sensitive and very specific about known obstructive coronary disease.
It's the gold standard.
Which is the gold standard, right. And then we've identified a few patients who have had some concerns, and this was in a screening modal, and they had risk factors, but they didn't have symptoms. Now, there's a little bit of evidence behind, that's where it comes in that gray area of wellness, right? Because there's probably no big evidence on screening stress EKGs, but I don't think that's been tested in the public. It's just large populations. But that being said, in our small group of patients, they've seen some benefit from it.
Do you order CT scans that look for calcium scoring? Do you order those tests?
Yes, I do.
What do you think of those tests?
Pardon me?
What do you think of those tests?
So, it's a great question. It gives you that 3 levels, the mild, moderate, and the high level. And the funny thing is that when you do this screening test, it's a CT scan. It shows the burden of the calcium in the coronary calcifications. And it gives you the radiologist will give you a number, and that number will be in mild, moderate, or high level. The pre-test probability of these patients having high, I kind of knew that, The patient had diabetes, the patient had hypertension, the patient had high cholesterol. I kind of knew that this was going to happen, but it was in a younger male, so we identified it. In fact, it caught an area where there was a higher calcium burden in a certain coronary artery. It correlated with our stress EKG. It said, okay, we kind of were like, okay, it's time for us to at least talk to the cardiologist. And the cardiologist agreed with us that this is something in the direction that we should investigate. it led to an angiogram. And when they did their FFR, it was a very narrowed area. So the patient actually got a stent on there. It turns out that he was symptomatic. He was just not understanding that his shortness of breath when he got up the stairs was part of his symptoms.
Yeah, interesting.
Yeah.
There's a really good test, and it's fairly new, called the Clearly Heart Scan. And I have made it a goal in my practice not to order the CT calcium scoring. I have found and read that that is only measuring hard plaque, which is not always the dangerous plaque. The Clearly Health Score is a scan of the heart using AI-generated protocols. It can actually determine pretty well the amount of hard plaque, soft plaque, and intermediate plaque. And I've sent actually a few patients, much like you in this situation, to the cardiologist, that I think it's just a better predictor of cardiovascular disease in patients. So something to look into in the future.
So where are they offered?
Yeah, I usually offer this to patients who think of it as the vascular paths. So I'm very quick to encourage patients to think about doing that testing, even over a stress test. And I know some cardiologists listening may not agree with me. But I have read, I think this is truly a better predictor than the traditional stress test. And tapping into this trend of AI-generated protocols and looking at data, it will actually tell me as the physician what I need to do based on that amount of plaque burden in those vessels. And it's interesting, what we're going to talk a little bit more about GLP-1 therapies, but part of that protocol is actually encouraging patients to be on a GLP-1 plus or minus a statin plus or minus Zetia, because we know that the combination of these drugs may reverse plaque. And I've actually seen that in a few patients where they've had a certain degree of plaque burden, and after 6 months of being on Mounjaro, for example, that plaque is gone.
Wow.
And repeat clearly tested.
Really?
So it's pretty interesting. Yes. So I think, well, let's talk about GLP-1s.
Yeah.
What is a GLP-1, Dr. Zep?
Elephant in the room.
What are GLP-1s?
So GLP-1s are a class of medications. These medications have been around since the 1980s. It was derived from the toxin of a Gila monster located apparently in the area that you guys live. I've never seen it. I hear there's a lot of them out there. So it's
Bidurian, right? Was the first one, or Byetta?
Byetta, yeah, that's right. That's right. So say it was derived from the toxin of it. Basically, it is a peptide which has like a few different activities. One is it increases insulin production for the pancreas. Two is it decreases the motility of the gastric emptying. And three is it works on the hypothalamus and parts of the pituitary and helps reduce satiety and it reduces hunger, and in some cases has been shown to reduce like kind of the hunger pangs, but almost the addictive component of food and now other things as well.
Do you prescribe a lot of them?
I do. I prescribe them to diabetics who are overweight. And interestingly, I actually am prescribing this to my diabetics as the first line medication who are non-insulin dependent. And I think that's a different role that a lot of people, because to be honest with you, every time I bring up the standard of care prior to the past few years has been metformin, glyburide, glibazide, and then GLP-1s. And part of it was because of cost.
And that's how we were trained too.
Right.
So,
but no patient's asking for metformin.
Right.
No patient's asking for glibazide or glyburide. They're saying, I want to be on a GLP-1. And I don't blame them.
For new diabetics, new type 2 diabetics, do you start them still on metformin?
I actually start them on GLP-1s now.
Okay.
And it also depends like how high the A1C is.
Right.
If the A1C is 10, then we're talking different options. Absolutely. But if it's like 6.7, 6.9, 7, I'm considering that. I'm watching them closely. But
in your diabetics, have you seen significant improvement in their blood sugars?
huge.
Right.
Not only their blood sugars, their weight loss, their quality of life has improved. They're sleeping better because, they've lost like 30 pounds. So that helps out a lot too.
Do you prescribe this mostly for patients who are not diabetics and just looking to lose weight?
Yes. Yeah.
And have you had much success with that?
Yeah, I think actually, I'm going to be honest with you, more non-diabetics, obese patients come to us for GLP-1s, and we have had a significant success from that. The patients have success. Patients coming to our clinic for that. It's been you can tell, like, patients are loving it. There's a double-edged sword to that because, inherently my goal has always been to not, I don't want patients to be on medications for the rest of their life. My goal would be for them to eventually come off the medication.
Right.
I find that part difficult.
I think there are those patients, and we can get into this in a different episode, but I think there are those patients that truly have metabolic dysfunction. And we finally found a molecule that is improving the way the body utilizes and breaks down blood sugar and utilizes insulin more efficiently. And for the longest time, there was nothing that really did that. So you have finally a molecule that's improving hormones and also controlling satiety. Ozempic was something I prescribed for many, many years prior to Mounjaro. And it's interesting that from what I've read and looked at and seen, no one really talks about Mounjaro. The media and certainly Hollywood are talking about Ozempic mostly, but I've never really seen much in terms of talking about Mounjaro. And I don't get, I'm not part of the company. I don't work for Eli Lilly, but I do think it's a much superior medication for weight loss. It works on two receptors, GLP and GIP. And I know for me personally, I've seen a lot of benefit. Much to what you said, I am very quick to have patients show me that they're on a diet plan, show me that they are working with a nutritionist, show me that you are making the effort to lose weight. If you are doing that and you're still having some challenges, I think it is absolutely appropriate to consider some medications. And Mounjaro or Zepbound is one that I have had much success with.
Yeah, I agree with you. I think there's been a population of people that really benefited from Ozempic. I think the newer people who are coming to the clinic are asking for tirzepatide rather than semaglutide.
What is tirzepatide?
Tirzepatide is the generic version of the Mounjaro.
Perfect. Yeah.
So that is the one. So if you compare the two medications, they're very similar. Semaglutide is a GLP-1 agonist. Tirzepatide is a GLP-1 GIP dual combination peptide. Yeah. And realistically, these medications work very well. Both of them work very well. Tirzepatide has had just a better benefit, and now there's some studies for even comparing for cardiovascular health.
Right.
And
which is why I mentioned earlier with the Clearly test why Mounjaro was on that protocol for being a drug that showed some improvement with plaque burden. So I think there definitely is that cardiovascular benefit. I know Ozempic has that indication. I do believe Mounjaro will in the future.
Yeah, you're exactly right. Like any New England Journal of Medicine publishes all these great articles, but like the studies have been going on for a couple of years. So now like the windfall of all the studies that are going to come out, more and more data is going to come out about the benefit, the cardiovascular benefits, the cancer benefits.
Right.
We're going to see a lot more of that.
Have you seen it in those patients who've struggled with alcohol?
So that's a really great question. I've seen it in 3 patients. Now this was not in my regular practice. This was in patients that were prescribed it for diabetes. But they were also struggling with alcoholism. When they were dealing with alcoholism and they were prescribed Ozempic for their diabetes, they started taking it, they lost weight, and then they happened to also stop drinking. Now, they didn't necessarily attribute it to the diabetes medication, but it was an observation that I made that, interesting.
Yeah.
Because it's almost like they turned a switch.
Yeah.
All of a sudden that person is running. That person is taking, losing weight and stop drinking, and I don't see them in the hospital as much. So
yeah.
Yeah.
Liver enzymes are improving, they're getting better. What is the deciding factor between putting a patient on Ozempic, for example, or Mounjaro? Do you have?
Yeah, that's a really great question. Honestly, I think it's patient preference.
Okay.
I think for, at least in my perspective, I've offered
Cost?
Cost is huge. And I think that's
Yeah.
the perception is patients are asking. And I think also like some of the patients have come to us have said, I've been on Ozempic for 3 years. I want to continue that.
Mm-hmm.
And then some of the new ones are saying, I've heard Ozempic or semaglutide versus tirzepatide. I want to try tirzepatide.
Mm-hmm.
Okay.
Yeah.
And then like some of the patients who try semaglutide, they have more side effects,
Mm-hmm.
at least in the perspective that we've seen.
Yeah. I've seen, so again, going back to the pharmacology of this, so tirzepatide, which is the active ingredient in Mounjaro and Zepbound, actually activates those receptors 100% of the time. So you are getting a much stronger molecule, whereas semaglutide Ozempic is only activating it, I think, 20% of the time.
Yeah.
So I am very quick to only start out with the tirzepatide molecule. And I found clinically that if you start them out on it and they're having some side effects, it's interesting in my practice, patients then tolerate Ozempic.
Oh, really?
It's kind of vice versa. If you start them out on Ozempic and they're having side effects, they can tolerate Mounjaro.
Really?
I don't know why that is. So I always tell colleagues, maybe consider that if you start them out on Ozempic, they're not having that doesn't mean they're not a candidate for Mounjaro in the future, but flip it through it. So
have you had any patients have serious side effects from it?
I have not. No, I have not. I am very, very conscientious of taking the time to talk to them about potential side effects. I have 3 rules for patients. I tell them that this drug is not going to make you hungry, and you really have to make the effort to eat. So I say, number 1, you need to eat smaller meals throughout the day.
Sure.
No one says it's normal or you need to eat 3 large meals a day.
Yeah.
I think physiologically it's better to eat smaller meals throughout the day, and I think our nutritionist friend would agree with us here on that, but smaller meals throughout the day to maintain blood sugars and insulin levels. The second rule I say is you can go to your favorite restaurant, and if you're hungry and have 2 bites of that filet and all of a sudden you're full, stop eating, because you will, if you keep eating, you're going to get nauseous, you're going to get sick. And the third rule I have is this drug is going to meet you 50% of the time. Really make the effort to change your diet, eat well, get on an exercise routine, because it's going to meet you halfway.
Yeah.
And I think patients are eager or more enticed when they finally, for the first time, are seeing results.
Yeah.
And it's what I like about this drug is it is changing the mindset and creating new healthy habits that I've never seen in other patients before. So I think people just needed a little bit of that push to finally see results, which motivating them to move forward and make good choices.
I think that speaks to a bigger thing that's happening in the public right now. There's a fight back to the GLP-1s, and that was expected in public.
Right.
So there's the group of wellness providers that are feeling that, this is a pharmaceutical medication, that people should be, strong-willed, do it the hard way. And you know what? There's a very wonderful American mindset, and I love it. The problem is that mortality, obesity, cancer rates are skyrocketing.
I think we have to do something right now.
Right now. And like, I think every one of the patients that I have seen, and honestly, like, not only patients, but family members I've had that we've worked with, every one of them have tried for a long time to do it the hard way. The dieting, the exercising, and some of them have been fad diets. There's a reason why fad diets came around, is because people were trying to find options. There are wonderful options like getting a dietitian involved in your life, and some people can afford to do that, and that's wonderful if you can. In my opinion, the GLP-1s are giving that opportunity for those who can't do it.
Absolutely. It's as physicians, it's a double-edged sword because you don't want to commit to this idea that we're hearing a little bit more about, oh, you're just pushing big pharma agenda and your education came from big pharma and why are you contributing to this? It's a double-edged sword because on one hand, we have got to do something for our patients. And unfortunately, in some of these situations, medications may be the only option.
Yeah.
But yes, in a way, you see what I'm saying?
Have you ever tried to convince somebody into GLP-1 that didn't want a GLP-1?
I find that more, actually, yes. And it wasn't necessarily for the weight loss. It was more of, hey, I'm a diabetic and I haven't seen a doctor for several years. Right. I can't believe I'm diabetic. I don't want to be on anything.
Yeah.
So I think that was the only situation.
I think the point is that nobody comes to me and says, I'm looking for weight loss, but I do not want GLP-1s. Mm-hmm. I'm not coming out to the public and saying, this is the only option. This is the option for the people who are asking for it.
Right.
And for those people, I'm fairly certain that those people have struggled.
Right.
They've struggled, and they're at a point in their life that they see the number one risk factor, which is for mortality in the United States, is coronary disease or heart disease. Mm-hmm. The number two is cancer disease, and they're thinking obesity is like the major risk factor for all these things.
Right.
What can I do to reduce that risk?
Right.
If they can quit smoking, if they can start walking, they will try it.
Right.
If they can help themselves with obesity, they're going to try it.
Obesity is, by definition, a medical condition. I treat it the same way as heart disease or any other condition. And, I do feel, sad for this demographic of people who are overweight. And it is not necessarily what they have done wrong. I mean, this is truly a hormone problem. So it's exciting to see. I think going back to what I was alluding to earlier, as doctors, it is a catch-22 because on one hand, we've got to treat the patients. But I agree, I'm not one to really want to always put patients on medications either. And I don't think you do as well. So
you're exactly right. It's a catch-22. You're trying to find that balance. That is this the right medication for them? Is medication even an option for them? Mm-hmm. Can we just go for a walk, or can we do this options? Increasing exercise activity. I mean, talking about, you were mentioning how you deal with it in your practice. A big thing for me is, our patients, when they are screened, they get a screening evaluation from a dietitian, which is extremely important. And I'm adamant about exercise in these patients. Like, you can't just take these medications and then just stay at home. You have to be building muscle, because the amount of fat and muscle you will lose is astounding.
Right.
And that,
have you seen that in patients?
Yeah. That has actually been, I think patients don't acknowledge the muscle loss as much as the physicians do.
Right.
And the patients are just happy that their weight is down, that they're fitting into the pants that they wanted to.
I've actually taken patients off of the Mounjaro because of their muscle loss. So doing in-body compositions and seeing the amount of muscle loss I have, especially older patients, as you know, muscle wasting, that's not only hard on the bones, bone loss. We know right then and there that is a huge mortality factor, especially in older women with osteoporosis. So patients who are on this have to exercise. They have to get the protein in.
Yep.
If not, I mean, I think it has its side effects.
Yeah.
It's consequences, I should say. Talk to me about those patients that you have seen weight loss. They are at their optimal weight loss goal. Do you suddenly stop it? Say they're on the maximum dose.
Yeah.
What is your approach, Dr. Seth?
Yeah. My approach always is to have that conversation with the patient. Are they ready to come off, or are they not? Mm-hmm. if they're not ready for that medication to come off, then it's not time yet. I do start off every program by saying, I don't want this medication free for life. There's a lot of doctors out there that do believe that this is a lifelong medication. And maybe in some patients that is the option for them. I don't think that that's how we should start off. I know this sounds crazy, but when I've started blood pressure medications, I've always said my goal is to get you off this.
Right. That's my goal. I always say, if I'm putting you on this medicine, the next goal I have is, when can I take you off?
Right. And I think that's how it should always be. The problem is life gets in the way. Try getting a 60-year-old male who has hypertension, hyperlipidemia to, make a major lifelong change and to drop their blood pressure significantly. It's super, super hard. That being said, I do think that there is an option.
Right. Do you find that even the approach to patients, or even the discussion about coming off of this, do you find that they're a little bit confrontational about wanting to come off of this?
Yeah. Patients who have lost weight are so happy that, it's been a huge life change. In some cases, their marriages have gotten better.
Right.
Their lifestyle has gotten better.
My marriage has gotten better.
Yeah. And you understand, like you say, things are much, much better, you know?
Right.
And so in these situations, you're like, the patient will say, I'm not going to change it because right now things are going well.
Yeah.
And at that point you say, okay, well, it's something we just have to keep following.
Yeah. Patients ask me all the time, what are the long-term consequences? And I don't think we have that. I do worry about biliary function, biliary transit, pancreatic function, thyroid. I've not necessarily subscribed to ordering thyroid ultrasounds periodically or whatnot. I
remember I think like the thyroid, the risks, the risks on like the labels say like pancreatitis, which there is a slight increase in pancreatitis from the general public. The thyroid and the multiple endocrine neoplasia group, the thyroid group, I think it was tested on rats, and there was a certain type of cell, C cells that humans don't have, that it was an issue. But that was it hasn't been necessarily translated. I think part of the safety aspect of this is, this has been a medication that's been around since the 1980s.
Right.
And I'm not saying that it's 100% safe, but it's a relatively safe medication.
It is. As with anything, it comes with its side effects. Aspirin has side effects, for example. But I think just doing the early good screening first off is important. I'll tell you my approach with patients, and I don't know. What I have seen, it's worked pretty well. But if I get a patient to an ideal body weight, if they're on the maximum dose, I slowly start trending down to what I have called a maintenance dose. So whether that is the 5 milligrams of tirzepatide, I will space that out every 10 days. If we get them to the 2.5 milligrams, I'll still have them do that weekly. And for the most part, patients have done well. They may not be losing more weight, but they're certainly not gaining weight. At some point, you kind of pause and think, is this drug making you lazy, though? And I have taken patients off of it, and I would say I have 100% record that patients are gaining weight. Why? In a way, I was hoping that this drug truly improved metabolic dysfunction, which it does. But when you're off of the medication, what is happening? Are their hormones changing? Is it their diet that they're eating? Is it the overprocessed foods that's controlling our hunger? Are they getting back into those routines? So it's an interesting idea.
A couple of my patients that have described the benefits of the GLP-1, in particular tirzepatide, they have described they're stress eaters. That's how they describe their lifestyle. They're very stressful lives, very stressful businesses. And when they were under stress, the second option they had was, other than work, was let me fill that void with, whatever food item it was.
Right.
It wasn't physical activity. And so that stress eating has been there for many decades. The medication in these patients' experience was it removed that need for stress eating. Now, it didn't remove the stress, right? The stress was still there. The work was still there. It was the crutch that I have to go and eat something. That conversation in their brain was gone. And I think that was a huge eye-opener for me.
I think there's an insecurity there too with patients, right? So they have achieved this amount of weight loss, and there's that insecurity that if it almost becomes this crutch where if I don't have this, I'm going to absolutely resort back to where I was before.
Yeah, absolutely.
So,
and it does speak. There's a number of doctors who speak very confidently about GLP-1s in the public, and one of the things they often say is, consider their mental health as well. In addition, and that is an extremely great point.
Right.
That obesity didn't just happen because of the preservative foods.
Right.
There is multiple levels on that. And when you say it's a disease, absolutely it's a disease. It's a mental health disease. It's a hormonal disease. It's a disease regarding food and GI issues. It's a disease.
Yeah.
It's a multifaceted beast.
Yeah.
And this is one option to it, but we should also, as clinicians, keep involved about the mood of the patient as well.
What is the future of GLP-1s in your opinion?
I don't see it slowing down. I've been reading studies that were published in some very high-end journals about medications that are coming from like GLP-1s in China, one being developed in Japan. I actually think they're going to develop more to reduce the risks of some of the side effects like muscle loss.
Mm-hmm.
And I think like it's going to be, a very interesting next 5 or 6 years of medications.
There's a new one, I think by Eli Lilly, that's supposed to be released that's actually working on 3 receptors. So I have read that it will blow tirzepatide out of the water.
Yeah.
So it'll be interesting to see.
Yeah. And I mean, it was eventually going to happen, right? The next big thing and these sort of things. And I'm glad that pharmaceutical companies have decided to put their attention to obesity.
Yeah.
I think that was a big issue in the country. That's a big issue all over the world. I deal with patients, inpatient hematology patients.
Mm-hmm.
And whenever I would deal with a patient who was diagnosed with like a lymphoma and they were morbidly obese, and they may have been a smoker, they may not have been a smoker, whatever the risk factors are. In this patient, the risk factors were, obesity. And watching them go through the treatment of certain lymphomas, watch them go through the treatment of cancer treatment, chemo treatment, I am such a big fan of these GLP-1 medications. Mm-hmm. Hopefully it can prevent this potential risk in the future.
Yeah. Yeah. Making a segue a little bit. So GLP-1s, I could talk about them forever. I think they're exciting. It's fantastic. Other wellness services I want to talk about are what you and I have in our offices, the hyperbaric chamber. So do you love it? Do patients love it? Talk to me a little bit about what hyperbaric medicine is.
So hyperbaric medicine is providing pressurized, high-level oxygen derived to all the body's tissues at a higher level and a higher partial pressure to get a higher amount of oxygen to compromise tissue. Yeah. Oh, that's perfect.
I love that, right?
Jinx.
Yeah. I think I gave you that line, right?
But did you?
I think so.
Yeah, compromised tissue. So like the gold standard use of it is for diabetic foots, right? So diabetes is a vascular disease. Mm-hmm. Their blood vessels narrow to the point of like this. Blood flow doesn't get to the end of the toe. It starts to get, ulcerated and it gets infected. And then, that's some of the pathology with diabetes. Mm-hmm. These patients go through surgical debridement, surgical resection, And then the goal is hopefully it heals. But the problem with diabetes is because it's a vascular disease, that blood flow isn't good.
Right.
So because the blood flow is not coming to that wound, it may not heal as well. So in patients, we send them to hyperbaric chambers to increase the partial pressure of oxygen to that compromised tissue. So it works really well in them.
Works very well.
Why could it not work in all sorts of different parts of your body? And now, fortunately, there is a lot more data. I would argue it's not enough data because, there's no, I mean, in all honesty, you can't pack hyperbaric into a pill.
Right.
So there's not a lot of impotence for pharmaceutical companies or something like that to find huge data sets to do this. So the studies, a lot of them have been coming out of like in the Middle East. For some odd reason, there's a lot of like diving medicine colleges that do them, and so what's really crazy is, and I got like 3 really great studies when I was trying to understand a little bit about this. So there was a great study where they took patients out of the VA, 75-year-old patients, and they did skin biopsies of them on day 1. So they took them into 2 groups, group A, group B, biopsied both of them, okay? And then after 60 days of 1 hour a day in a hyperbaric chamber, then they took the repeat biopsies of them, okay? And they found that those 75-year-old patients had increased collagen fibers, increased elastin fibers, and decrease of the senescent cells, the senescent cells. Thank you. And I was thinking, is this like a real? So in other words, you're developing a protocol to improve the skin of a 75-year-old. At that point, historically, culturally, we've just kind of said it's time for us not to do all this this stuff, and this is providing in a group of men at the VA, for example. So I thought that was a really, really interesting aspect, and so I was using it myself. I use it for myself just for kind of overall wellness, and I've noticed
a difference.
Yeah, I've noticed, like, especially after I do it, that day I sleep extremely well.
What has been this whole trend and popularity with hyperbaric? What has really fueled this?
I think there is a little bit of public acknowledgement. I think a lot of the wellness in general.
Do you think it's just a trend, or do you think it'll catch on even more? Do you find that more physician offices, more concierge offices are going to offer this?
I think it is. I mean, I do think in general, medical wellness is trendy, but I think this is one of the things that will catch.
Yeah.
I've noticed that hospital systems are building them into their programs.
Yeah.
And that's never been there because, to be honest with you, the payment's not really good for hospitals, so they don't really put a lot of emphasis on it. But now if patients are willing to ask for it, I think that's been a big thing.
Right.
And whenever you see the hospitals build a wing for it, you're like, okay, we're in the right direction. Something's happening. There's a demand for it. So yeah.
I love it in my office, and I advertise it mostly for post-surgical healing. So for patients who are undergoing small procedures, plastic surgery, I will tell you hands down, it expedites healing. So that's part of our built-in. We have pre-surgical and post-surgical plans involving hyperbaric. I don't feel it's a trend. I think it's going to catch on even more. And in my office, I think in your office as well, it's done great. So,
you were the one who inspired me to get the hyperbaric. And I remember you saying, like, this is one of those things that you should consider.
Yeah.
And
I think it's a way of setting you apart too, Dr. Seth, as a concierge doctor. I mean, it highlights that you as a physician are looking at other wellness options for patients, which I think is outstanding. Obviously, we have the time and ability to talk about advanced markers and biomarkers. We have the time to really take a deep look into patients' health, and I wish there wasn't necessarily a need for concierge medicine.
Yeah,
I think every doctor should have the time to really offer this for patients, and unfortunately, the system just doesn't allow that. Profit and volume over quality of care seems to be that trademark. Also for another discussion.
Yeah. Yeah.
Other wellness things I want to highlight quickly are the wearables. So the Garmin or the Apple Watch. Talk to me about that.
So, boy, I have a love-hate relationship with the wearables. You know, the wearables. So I think we need to differentiate the difference between the wearables and the actual medical devices that are provided by medical companies. The the companies that make pacemakers, they provide Holter monitors. Those are the gold standard monitors for heart rate machines that identify it. They have a cardiologist read it. They have a cardiac tech review everything. They know the ins and outs.
Yeah.
And then there's the wearables, the Apple Watch, which says you have a high heart rate, you have a low heart rate, and if you hold it here. Now, is the sensitivity and specificity very similar? I don't know if they've been tested as highly. There's questions about that, but I can tell you my personal story. I was on a Stairmaster. I was really giving it. And my heart rate was climbing. And then all of a sudden my watch buzzed and it said very high heart rate. Well, I panicked.
Were you an AFib?
Well, so I tried. So the funny thing is, like, you have to like hold it with two hands. I'm like sweating profusely. I'm like holding it, shaking, this running, and I'm like, oh, I'm my AFib. And then my heart rate went down, right? So I didn't catch the AFib, right? And now I'm like, well, what happened? So then, you know, I'm worried. I've got kids. If I'm an AFib, if I have AFib, I should reduce my risk and be on a, preventative medication for that. So I need to know. So I called my friend who's a cardiologist. He's like, all right, I'll get you a Holter monitor. That thing was annoying because I still worked out. So I'd go on a treadmill and I would get a phone call like, excuse me, doctor, your heart rate's really high. And I'm like, yeah, I know, I'm on a treadmill. Okay, fine. And that was, I think it was like $4,000. And then I had an echocardiogram. And then I had a stress test. I hit my deductible that year. And then it was so expensive, and all for me to be told, you're fine.
You're fine.
Yeah.
You're fine.
So I do find, and, working in the hospital, we would often have some patients who would say, I had this little heart rate issue, came in, I have chest pain. Yeah. Okay. And we'd work them up, and many times they were negative.
Yeah.
I don't know if I've ever seen them to catch something real, but I'm sure it's happened.
I feel like the technology is quite not there yet.
Right.
And many patients will constantly show me their phones, show me their watches, show me these wearables, and I don't necessarily pay attention to them that much.
I wonder with like AI coming involved, if that is going to change the game. Is it going to be intelligent enough to say, this is something you need to be worried about? Tell your doctor, or is it going to hyper sensitize that and bring more? Your temperature dropped at some point. Go see your doctor.
And for patients, and those patients that you can spin them out of control, right? And then you're dealing with all of that anxiety and stress, and it's unnecessary.
I was noticing that there's these wearables that track your sleep, and so one of my friends were posting them about their sleep, and they always had these like erratic sleep patterns. And, I was just texting them, like, what do you think about this? Like, and I noticed like, you're not posting anymore about the sleep. And she's like, yeah, because I never slept because I was so worried about my sleep. Now I don't have the tracker on. I sleep well.
In closing, are there any other wellness services that you think you would like to offer your patients that are beneficial, worthy of their time, worthy of your time to do?
I think there are some. I think some of the new stuff that's coming out, like the peptides, some of the HRT conversations out there. I'm very, very critical about some of these things. But there's some evidence out there that patients experience really good lifestyles from it. And so I think that's something to investigate. we haven't really decided how we're going to go in that direction. I think I have noticed that patients ask for it a lot.
Mm-hmm.
And what I worry about is that in the current world we live in, there are places that will provide hormone therapy without a blink of an eye.
Scary.
And not look at medical history. I went to one of these training sessions and I sat with them. I learned, and, I would argue some of these patients, some of the providers didn't have a lot of medical background, a lot of medical knowledge background.
Mm-hmm.
And, I respectfully, they were still, very interested, but if you talk to them, it was the end all be all treatment for everything. And even if the side effects were there or the risk of cancers were there, they kind of brush it off. And not the teaching people, just some of the students there. And I worried that what happens if that's in the public?
Right.
Right?
You find that these entities, almost like a mill, right? Where these patients are coming in, looking for answers, wanting maybe the next quick fix.
Right.
And just being given tests or given therapies that may not be the best for them.
And the thing about being a physician and a clinician that's super important is you have to know when to say no.
Right.
And the problem in our society is if you say no, so now on the street will say yes.
Right.
And how do you educate them? How do you get through to them to say that's really risky?
In closing, I will say the answer to that is having a relationship with your physician, and why what you and I do is so vital and critically important. I wish everybody could have a concierge doctor. I wish we could go back to those days from a simpler time long ago where the doctor of yesterday really had the time and the ability, where the system allowed us to succeed and be there for our patients. I think it is so important to have that relationship with your provider that's unmatched. So many patients in this country are seeing providers that don't know anything about them.